Thank you very much, Liz. We'll try not to lock the doors if you do get bored with my talk. I apologise. Some of you may know that I do like to talk. I'll try to stick to 15 minutes. I'll fail, but we'll see how we go. So there are lots of people in the room. We all know what brain tumours are, but I'm going to just start from the very beginning, if that's okay. Okay, we know that brain tumours, to put it very simply, they're a massive abnormal cells that shouldn't be within the brain or within the skull. They can be primary tumours, they can be secondary tumours, they can be benign, they can be malignant. They can affect us in many different ways. They can cause specific neurological problems. They can impair our movement, they can impair our language, our speech or our vision. And more subtly and more insidiously, they can impair our psyche. They can affect our relationships, they can affect our insight, memory, judgment, mood, and that's really the basis for why they have such a profound effect, not just on ourselves, but on our broader family. As part of the talk about surgery, I'd like to just talk about how we discover tumours, how we briefly investigate them, and that surgical part of the journey. The brain tumour process, as we know, really is a journey. It starts off with surgery often, the baton gets handed on to the radiation specialists and team, then the baton gets handed on again to the medical oncology specialists and team. But in the surgical, the initial part of things, we discover tumours through a variety of ways. Tumours can present with headache, seizures, of course weakness, language problems, vision problems, confusion, or they can be simply found by chance, and this is getting increasingly more common as we have increasing access to MRIs and CT scans. So what happens when a tumour is found? Well, a CT is usually the first test that's done. It's often organised by a GP or in the emergency department, and we see something that shouldn't be there. Now, when we look at scans, some of you are well versed in scans. I try to show all my patients every scan that they have, and the brain is three-dimensional. So when we look at it on a screen like this, we slice the brain up like a loaf of bread just to render it in 2 dimensions. And we can see that on the right side of the screen there, which is the left side of the brain, there's a lump that looks unusual. So what's the next step? The CT is good, it's easy, it's quick, but it doesn't give us enough information. The MRI is really the next step, and you can see things in far greater detail. It's more useful for me because I can help plan with you what needs to be done next. Unfortunately, an MRI can be slow. It's not easy to get compared with a CT, but it does allow a greater degree of planning, but not everybody likes to lie in an MRI scanner for 40 minutes at a time. It's not very pleasant. I've done it. I actually found it pleasant because I got to turn the phone off. I loved it, but not everybody can cope with it easily. Occasionally we may need to do special MRIs. We might need to do functional MRIs. We may need to look at different motor tracts in the brain. There's no way to turn the lights off at the front, is there? Just to clarify? No, I think that's just the display. Can everybody appreciate the imaging that's projected up? Yep, all right. Special MRIs can help me plan what to do to create the least disturbance possible. Sometimes we'll do very special MRIs looking at spectroscopy, the chemical composition of various lumps in the brain, the molecular characteristics. Sometimes we may do PET scans, positron emission scans, which look at the metabolism of tumours in the brain. That can be useful for me to plan, and it can give us a sense of prognosis. That is a lump more malignant or less malignant? Before we launch on to the surgery side of things, often we may need to give various treatments. We may need to start steroids, dexamethasone. We may need to start anti-seizure medications. We may need to stop any blood thinning medications. And of course, there's a discussion about work and driving, which is really the preliminary chat about how life does change when a brain tumour is found. Steroids, well, we all know about steroids, dexamethasone. It's the most common drug, which we've all had experience with. It's a fantastic drug, and it's a dreadful drug. It's used to treat brain swelling, cerebral edema. It's very potent, it's very powerful, but it's got a lot of downsides. I'm not going to go through all of those, but we've all seen some of those downsides. It's a necessary drug. It's incredibly useful for me, but we don't like anybody to be on it for longer than is strictly necessary. Anticonvulsants, well look, there are so many anticonvulsants, I lose track of the different anticonvulsants coming on the market. There's Keppra, which is probably the most commonly used for us these days. Dilantin is one of the older style medications, and we've got a lot of people in the room who will have experience with this. But unfortunately, the side effects of anticonvulsants are legion, and we don't like to use them unless it's necessary, so we don't use them unless somebody has had a confirmed seizure. At least that's my practice. So now it's on to the intrusive bit of what I do, surgery. I still think it's the necessary and the best treatment for many tumours. It's necessary so that I can hand tissue on to Dr. Rodriguez in the back, a neuropathologist, so he can tell me exactly what type of tumour we're encountering. Surgery is necessary so that we can remove as many of the abnormal cells as we can. And in some cases, surgery affords an opportunity to cure the brain tumour. That's a comic I saw when I was 11 years old. I wanted to be a doctor soon after that. I don't think that was the trigger, but it could have been. Benign tumours. Well, benign tumours, meningiomas, are tumours that can be potentially cured by surgery alone. Of course, it's important to look at the location of the tumour and the surrounding structures, because they're hurdles to Jonathan and myself performing safe surgery. But malignant tumours are more the focus of today's discussions. And for malignant tumours, as a surgeon, I try to achieve a gross total resection. Now, what that means is that we turn a scan like that, and we see where the white lump is, into a scan where there's no white lump. That is, all the abnormal tissue that we can appreciate on the MRI is removed. But a gross total resection, that's the wrong word, because we never take out all of a malignant tumour. We can't, simply because there are microscopic tendrils which have been sent out, but we know that if we get as much of the tumour out as is possible, that's the best possible thing for our patients, for our friends who have these tumours. Unfortunately, we do it a lot better than we used to. I love this picture. Does anybody know what this is? It's a skull. But the fascinating thing about this skull is that there's a hole in it, okay? And this skull, the hole in it, has rounded edges. This is a skull that was discovered in Mesoamerica, and it stems from 3,500 BC. So we're looking at 5,500 years ago. It's a young girl, probably in her late teens, early 20s, and this girl had a hole drilled in her head, and because of those rounded edges, she survived the procedure. So neurosurgery's been around for a long, long time, and we do it much more efficiently and better now than we did then. This is a type of Hudson bit from the mid-18th century, okay, the mid-19th century, 1840s in Germany. It's one of the old ways we used to get access to the skull. It's confronting, isn't it? It's confronting, but it's also beautiful, beautiful instrument. We're much better now, thank goodness. So I've said that gross total resection is my aim for surgery, but it's a bit of a misnomer because I have to take into account the important portions of normal brain which surround a tumour. And one of the challenges which I have to face is to differentiate the normal brain from the tumour. So how do we do this? We've got a variety of techniques. We may use stereotactic navigation. That's where we program in a preoperative MRI scan into our surgical navigation computer so that we can map exactly which parts of the brain we believe are most affected. 5-ALA, some of us may have been exposed to glialan during surgery, which is a technique that under the microscope enables tumorous tissue to fluoresce and become more visible when compared with normal brain. Some of us may have had surgery with an intraoperative MRI. Some of us may have had surgery awake. Okay, there are many techniques that we try to tailor in order to achieve the best possible resection with the least possible effect. These are some of the pictures that I see when I'm planning surgery, when somebody's just about to have an operation, and I can plan the best trajectory through the brain to resect tumours. Intraoperative MRI scans, it's a lot of very expensive technology, awake craniotomies. Some of us may have seen on YouTube people even playing the violin or the guitar during surgery. It can be done. This is a picture of somebody who's had the glial, which enables the normal brain to be distinguished from that brightly fluorescing tumour. So there are a number of techniques that help me, that help Jonathan achieve our aims of taking as much tumour out as possible, but minimising the intrusion to the surrounding brain. So after surgery, what happens? Well, people will usually be in hospital anywhere from just overnight to 5 days, or occasionally, if there's a complication, much longer. My aim is to maximise people's safety, to maximise their physical capacity, to maximise their cognitive capacity. And also, and I think we all don't emphasise this enough, but maintain people's mood and outlook on life in a positive way. Okay? I want people to get back home as quickly as possible, as well as possible, and I want a scan that looks like that. And I think that surgeons have lifted their game, because we've had to. We've got these better aids in surgery with navigation, fluorescence and MRI, and we've got better quality assurance techniques. I think that caring for people with brain tumours requires a real ecosystem. There's an ecosystem with oncologists, both medical and radiation, pathologists. Unfortunately, Michael often gets ignored in the back, Dr. Rodriguez. We need, more importantly for the future, people such as Kerry MacDonald to help guide our way forward with better treatments. Brain tumours are a journey, and surgery is a crucial and important first step in that journey, but it's by no means the most important step. And I said before that we hand the baton on. And in that vein, I think it's time to hand the baton on to Sue Coe.